Доброго вечора, радіаційні онкологи, медичні фізики та радіаційні терапевтичні технологи. Ми знову раді вас вітати на курсі Cervical Cancer Brachytherapy Course for Ukraine, що організований Brachythera у співпраці з Help Ukraine Group і за підтримки Cervical. Я нагадую, що протягом цього курсу у нас вже було декілька живих лекцій. Сьогодні така лекція, що носить назву Clinical Case for Radiation with Brachytherapy. Ще одна така лекція, де ви можете поставити запитання та отримати відповіді на них від експертів з Brachytherapy, буде 2 вересня. Вимоги до успішного завершення цього курсу – це пройти 100% асинхронних лекцій на платформі Brachythera, відвідати щонайменше 80% живих лекцій, скласти підсумковий тест із результатом більше 80%. Проходити курс ви можете на веб-сайті Brachythera. За вашим імейлом ми отримали посилання для того, щоб проходити цей курс. Це зручно зробити з імейлу отриманого. Також ви можете зайти безпосередньо на сайт Brachythera, в проєктах цієї організації знайти як курс для України та залогінитись до свого дашборду. І таким чином проходити курс. Тут ви бачите прогрес, який ми маємо на сьогодні. Як я сказав, ми бачимо, що багато людей повернулися, можливо, з перерв літніх і продовжують проходити курс, але середній показник поки що 24%, а курс завершується вже 15 вересня, тому ласкаво просимо всіх продовжувати слухати лекції та здобувати знання. Я також нагадую, що вже відкрилася реєстрація на практичний тренінг, що відбудеться в Польщі. Кількість місць там обмежена, тому, будь ласка, реєструйтеся. Одною з умов для того, щоб бути обраним і поїхати на це тренування, є якраз таки успішне проходження онлайн-курсу. Що ж до нашої сьогоднішньої лекції, то це дуже цікава тема, саме рей-радіація. І сьогоднішнім нашим в брахітерапії, сьогоднішнім нашим спікером є доктор Марина Соколовська. Вона є доцентом та кандидатом медичних наук, керівником Центру радіаційної онкології Національного інституту раку, що в місті Києві. Вона є радіаційним онкологом з більше ніж 20 років стажу, більше ніж 20 років досвіду в клінічній дистанційній променевій терапії, брахітерапії і ортовольтній терапії. Вона має 11 років досвіду навчання як доцент радіаційної онкології Національної медичної академії наук Шупика, що займається післядипломною освітою в онкології. Вона також має ступінь магістра в державному адмініструванні. Вона є учасником і постійним лектором на українських та міжнародних конференціях. Вона є членом Астро, Brachy Academy. Вона є учасником та лектором ініціатив і тренувальних програм Help Ukraine Group. Вона також є активним учасником міжнародних клінічних трайлів в специфіки head and neck, lung, також гінекологічний рак. Вона завершила 2 observership в Крісті та Miami Cancer Institute в США. Тож, ласкаво просимо до мікрофону. Марина, подіум ваш. Уважно будемо слухати лекцію.
Hello, everyone. Hello, Christian. Nice to see you today. I will share my screen. Sergey, please stop sharing. Thank you, Sergey, for your kind introduction. And first of all, I want to thank the organizers for this outstanding course. And it's a real honor to be invited as a speaker today. let's talk about radiation in cervical cancer, but firstly, I have a small lecture about this problem because it's quite challenging every time. So after primary treatment, from 30
Pani
to...
Maryna, Pani
Tak.
Maryna, do you mind going to the first slide and putting it in presentation mode? Because right now we're seeing the question one.
Okay, because I have presentation mode and it was good for me.
Share the whole screen.
Can you see my screen?
It's again question one. Go to first one and put.
And now? Is it from the first slide?
Go to the first slide.
Something.
So when you click share, choose the option desktop.
Okay.
And
now, is it okay?
Yes, now it's okay.
Okay.
Thank you.
So thank you. After primary treatment, from 30 to 40% of patients with cervical cancer develop a recurrent disease. And half of these recurrence are local-regional. They occur within the previously irradiated pelvic field. The prognosis without further treatment is very poor, and as it was shown by Summers and colleagues, so 5-year overall survival without treatment at recurrence in the irradiated field, only 1%. For central recurrence, several publications recommend pelvic exenteration or radical hysterectomy. For non-central disease, it could be individualized irradiation or resection. But surgery on previously irradiated tissue is technically challenging, and for many patients, it is simply not an option. So the irradiation has become an important treatment strategy in this case. The first study that I observed was by Mabuchi and colleagues from Japan, and it was published in 2014. This retrospective study compared 52 patients treated with HDR interstitial brachytherapy with 23 patients who received palliative treatment only. And it was shown that there are few factors with better outcomes. First of all, it's a disease-free interval longer than 6 months. Smaller tumor size at recurrence, and lower figure stage. Patients with none or only one poor prognostic factor achieved the greatest benefit from the treatment. So they received local control rate almost 77% in the interstitial brachytherapy group. And median overall survival more than doubled compared with palliative course alone. And this difference was slightly significant, with median survival increasing from 13 months in palliative group to 31 months after brachytherapy. But they achieved grade 3-4 late toxicity at 25% cases. For patients, it was even rectovaginal or vesicovaginal fistula. And the key message was that HDR interstitial brachytherapy can provide meaningful survival benefit in carefully selected patients. And the first question for this session, what are the 3 independent prognostic factors for poor outcome? It could be age, tumor grade, hemoglobin level. B, disease-free interval tumor diameter and figure stage. C, BMI. Status, smoking status, prior chemotherapy, and option D, AQD2 dose, brachytherapy technique and treatment center volume.
Okay, so we're waiting for people to answer. Currently, we have 52% answering, waiting for a little bit more. Yeah, I'll wait.
Related.
I will, yeah, we'll control it. So just a second. So we have almost 80% answering. Okay, I'm ending the poll. Thank you so much for your answers. I'm sharing the results. So majority of you, 48%, answered B, disease-free interval, tumor diameter, and figure stage.
Yeah, and this is correct answer that correlated with the previous slide and article, on that article.
Excellent.
Yeah, thank you to all. The next study is again retrospective analysis from Korea, published recently in 2023. And the authors evaluated IMRT-based radiation for intrapelvic recurrence. It was 22 patients. They achieved that in 90% of patients was relief symptoms. The 1-year overall survival rate was relatively at 68% in the first year and declined to 25 at 2 years. And this may be partially explained by the limited local control that was achieved. Toxicity was more than 18%. Grade 3 late toxicity, and again, it was presented patients with rectal, vaginal, and mesovaginal fistulas for patients. So the key determination of outcomes was almost the same with previous article. So longer interval between irradiation courses, small GTV at recurrence response to re-irradiation. And these findings are consistent with those of the previous study. So, and emphasizes that importance of careful patient selection for pelvic re-irradiation. The next study by Ren and colleagues from China was particularly important because it provides the benchmark dose constraints that we will use in our case afterwards for cumulative doses in clinical case for our patient. This was a retrospective study of image-guided HDR brachytherapy, interstitial brachytherapy, with or without a BRT. Delivered with previously radiated area, and the median follow-up was 19 months. Regarding dosimetry, the median radiation AQD2 dose was 64 Gray, while the median cumulative AQD2 dose, including both courses, was 152 and more. And they proposed the median cumulative AQD2 D2CC doses to the organ at risk. For rectum, it was 115, for bladder, 130. And the range from 84 to up to 194 rectum, and 95 up to 173 to bladder. Again, it was a late toxicity almost in 40% grade 3, mostly because of urinary complications. And the median treatment-free interval was 13 months. And local control after radiation was achieved in more than 56 cases. Survival, they achieved 1 year survival 65%, and it declined into 27% at 4 years. Actually, these survival outcomes are quite encouraging and support the role of re-irradiation. the question when the radiation is appropriate. The answer comes from ASTRO-RTC consensus led by Professor Nicholas Andrachki, and many of you already know him from the Hague organized Astro Expert course. And I also had the privilege of collaborating with him as a co-author on this consensus on ray radiation. So they provide clear criteria for patient selection. So patients should have an ECOG performance status of 2 or less, expected survival of more than 6 months, limited volume disease, and acceptable toxicity from previous radiotherapy course. And it was additionally important to discuss each case with multidisciplinary team, discuss the risk of irreversible toxicity, to use modern conformal techniques, and access cumulative dose to organ at risk. And the next question, which treatment approach demonstrated significant survival benefit for locally recurrent cervical cancer in a previously irradiated field compared with the alternatives? So it could be a surgical treatment only, chemotherapy only, palliative care only, or ray radiation, especially with HDR interstitial brachytherapy. It's not so tricky question. I think it's obvious.
Okay, waiting for a little bit more people to answer. Okay, we have 80% of participants answering. I'm ending the poll and sharing the result. So 90% of you answered D, re-irradiation, HDR interstitial brachytherapy.
Yeah, that's correct. Thank you to all. And let's continue with our clinical case. So we had a female patient, 54-year-old, and she had the squamous cell carcinoma of the cervix. She was treated previously in an external institution in 2020. Unfortunately, we haven't any information about clinical stage because she haven't presented us any CT and MRI before an operation. We found only ultrasound where it was described solid cervical mass from 50 to 60 millimeters. It was provided surgical treatment, radical hysterectomy per Wertheim, and histopathology report was P21B and 1M0, squamous cell carcinoma G2 with stromal invasion to 10 millimeters and with bilateral pelvic lymph node metastasis. She received the adjuvant course of chemoradiation with a BRT on cobalt machine. It was prescribed at 40 grays, but without specification of the dose per fraction. With concurrent chemo radiomodification with cisplatin, and again without any documents, any medical records about the number of these cycles. After a BRT, she received brachytherapy on cobalt machine, 15 grays in 3 fraction. And in March 2025, on the follow-up visit was detected recurrence and patient referred to our institution. Histopathology confirmed recurrent squamous cell carcinoma G2, and she was PDL positive. The confirmation was again on pelvic MRI, tumor in the lower third of vagina with volume 13 on 10 on 13 millimeters, mostly on the left side, metastasis at the vagina. No urethral involvement and no regional lymphadenopathy was detected. On examination, it was hard because we found out obliteration of upper part of vagina, and it looks like the tumor spread from this obliteration and extending along the left wall to the lower third. Our decision was the next, as we couldn't provide brachytherapy appropriate with cylinder because of the obliteration. Again, we haven't interstitial brachytherapy, unfortunately. So the patient wasn't operable because of the spread of this tumor along the vagina. So the decision was to provide radiation with external beam to the recurrent site with concurrent cisplatin weekly and with pembrolizumab, followed by brachytherapy. And patient declined pembrolizumab that time. For the radiation course that was provided from September till November 2025, we did a BRT with VMAT, 45 grays in 25 fraction, locally only to the vaginal recurrent site. With concurrent cisplatin, weekly she received 4 cycles. Before brachytherapy, we did MRI, and it was complete morphological regression. But it was detected left inguinal lymphadenopathy, and it was considered at the time as reactive. We continue with brachytherapy. It was cylinder for that part of vagina that wasn't obliterated. With cylinder HDR, we decided to do 36 grays in 6 fraction. It was 6 grays per fraction at surface and 3.68 grays per fraction at the depths of 5 millimeters. And as we calculated that AQD2 at this 5 millimeters depth was 25.17 grays. On this slide, you can see the dose distribution from the EBRT course. It was VMAT radiation only locally to the recurrent site in vagina. Dose constraints and corresponding DVH curves. We achieved conformal coverage to the target with all those constraints. That was good. For the brachytherapy, we had a gut view and 2D planning. As you know, it's with the cards, and those not allow us to precise volumetric dose evaluation. Our physics did the 3D reconstruction of this curves from these maps, and we put it on the EBRT planning CT. So together with the approximate tissue deformation after application removal. And we evaluated after that cumulative dose distribution combined EBRT and brachytherapy. So here you can see axial and sagittal dose distribution above from EBRT treatment and below from brachytherapy. This gives us a visual overview of the combined coverage. And on this slide, medical physicists performed a fusion of the cumulative doses distribution. It's combination of EBRT and brachytherapy in a single image. So it was the most complete picture we could generate given the available data. We did the calculation of the total cumulative doses to the target. On the left side, it was cumulative doses from the previous course in 2020. And as we calculated, the patient received 56.25 grays. And on the right side, it was our course calculations. So this for the surface, we evaluated that she received 92.25 grays, but to the depth 5 millimeters, almost 70 grays. And we summarize these doses from both courses and achieved 128.17 grays QD2 that corresponded to the REN study, as you remember, the median dose was 152. Here it's a table summarize reference thresholds values that guide the radiation planning from ABS working group and published different articles. We can notice that the median cumulative QD2 dose to the target across multi-course radiation series was 108 grays, with deviation from 92 to 123, and doses D2CC to the bladder and rectum as from the REN article. And for those constraints, we again did the summary. Our patient received rectum D2CC from both courses, 82.8 grays, to the bladder D2CC, 90.4 grays. And with comparison to the literature with REN, we can see that her cumulative rectum dose was in the range interval ray radiation in REN article. If we summarize the both courses, it was 141.55 grays QD2, that again inside the interval of cumulative doses from REN study. And for the bladder, we have the same frames, and we are in this margins as in case of ray radiation and for cumulative doses. Yeah, it's our result, cumulative dose to the bladder, 149.15, that correspond to the literature. But unfortunately, in 3 months on the regular pelvic MRI, it was detected progression with involvement of left iliac and inguinal lymph nodes. It was confirmed prolongation morbi, was confirmed on PET-CT in a month, metabolically active para-aortic pelvic and left inguinal lymphadenopathy, but no reliable evidence of local cervical cancer recurrence wasn't on this imaging, so we achieved complete response. And she received, after this systemic chemotherapy with pembrolizumab, she received 6 cycles with 40% of positive response. And of course, I have a few questions. The first one, what interval is safe for performing ray radiation to radical doses? What cumulative organ at risk dose limits apply for radiation planning in cervical cancer? How should cumulative brachytherapy dose be assessed at the surface, or as we do to the depth of 5 millimeters from the mucosa? How to correctly calculate cumulative doses when there is no reliable data from prior treatment, as in our case? And for central pelvic recurrence, how to choose between interstitial brachytherapy and SBRT for ray radiation? Thank you very much.
Thank you very much, Dr. Sokolowska, for a very interesting presentation. We are very happy to see Christian here at our lecture, and if you can help us with some of these questions, that would be great. So, starting from the first one, What is the interval is safe for performing radiation to radical doses from your experience?
First of all, congratulations to this excellent talk. And it's a little bit embarrassing for me, but I have to admit, probably I can't answer your questions because what we have in all these re-radiation setting is we have only a very few clinical studies, monocentric. You have shown some of them from Asia and from America. Everyone is using different methodologies to sum the doses. Everyone is using different summing strategies, and we are far away from any really clear dose constraints as we have for primary treatment. This is really a pity. Each of us is working on our own, and we cannot really rely on anything in the literature. Even the best recommendations, you would find a lot of misunderstandings there and a lot of difficulties. I think what you have done, Marina, is really excellent because you have just shown what has to be done, what we can do. I think this is so excellent. You showed what we have to look at, what are the important things, how to sum up the doses. I think you have also shown how you can arrive at some kind of combined cumulative dose. But altogether, I cannot help you much more. You are already a real expert in this field now. Maybe just some small comments. I mean, the interval which is safe. What do you think on the first question? What is your impression? I mean, here we have probably not. It's just a few months. What we see after the first recurrences, I have not seen in literature anything which is saying something against performing re-radiation right after the recurrence is diagnosed. What is your experience with that, or what your view on that, or others?
Yeah, it will be interesting to hear maybe our colleagues, but I think that if we have more than 2 years, we could reach to more radical doses. Definitely, if this interval more longer, it's more comfortable. But who knows? In case of our patient, it's almost a year after this ray radiation course, and she hasn't any side effects in these terms that we use quite high doses for the ray radiation.
Maybe this fits already with question number 2. Can you maybe just go back where you sum up those doses? This was this was maybe here. As far as I understood, this is the first tables are the schedules of the re-radiation case, or is this correct?
No, it was it's our radiation course, and the 58.75 grays, we evaluated that it's the maximum dose from that course because we haven't any medical records, and we decided that we will use the maximum doses that
from the first treatment. So the 58 is the first treatment, the primary treatment, and the 80 is the recurrence.
So the most pessimistic variant in this case.
And this is rather high. And if you go back maybe one figure more, you have this excellent fusion. And I was not completely aware of the recurrence was in the lower vagina, as far as you told us.
It seems that it's in obliteration. It's from the cuff, spread it for the walls to the lower vagina. So the EBRT course, as we decided, is not enough, 45 grays. And we could put only vaginal cylinder to 3 or probably 4 centimeters. I don't remember correctly.
I saw such a case 2-3 weeks ago, And it was a little bit different because the recurrence was also on the lower vagina, but the clinicians could really see that it's only on one side. It was only on the anterior side of the vagina. And we were using a multi-channel cylinder, so not just one source in the center,
I
but
understand.
so this means we were able to only activate sources on the anterior part of the vagina, and by that you can spare the rectum on the posterior side. And this is, of course, the beauty of brachytherapy, because in such a case you would get much less rectum dose, of course, and you could shape it in a better way. So especially for recurrence treatments, I think everything you can do to fine-tune your dose distribution is of course excellent. I think this is already question 2. I think for question 1 we got now answers. You see 6 months, 6 to 9 months. I would agree to that actually. This is also my feeling without any evidence behind.
Okay, and actually we haven't such progressive applicators on because it's an old machine, and it's not possible to shield it the rectum, especially that the spread was on the left side, most all left wall of the vagina. So on the anterior, in our case, it's not big good, I think.
Christian, which applicator were you using? Miami for variant or?
No, this is a little bit a secret now.
Okay.
There is a multi-channel applicator available from Elekta, which we are also using. But we also used the Elekta vaginal applicators with these cylinders, a few of them. You can put them together. And
Yes.
we drilled hole into that, and in those holes we just put the plastic needle. So it's actually a little bit a homemade. It's of course forbidden to do that, but
I see. Okay.
But we did it. But I think nowadays they have for Elekta they have this multi-channel applicator, and you mentioned Miami for Varian, I think it's called.
Correct. Yeah, I commissioned it before. Yes. Very
Yes. So from the chat we see that many of our colleagues have or had to treat patients within 6 or 9 months after the initial treatment, which is challenging, I think. I also can comment that obviously if the cumulative dose from both treatment does not exceed the constraints, so it's safe to re-irradiate, but also what sometimes is used as a rule of thumb that after half of a year we consider that maybe half of the dose can be neglected, which is obviously not for organ at risk at this localization, and also not for humans, as have been studied not on humans that showed this. But as far as I know, this is maybe the only one that shows something like how to calculate this. But we also had a question in the chat. In those studies from Asia, for example, this might be a question from Marina, but also if you, Christian, know about that from Asia paper, was the recovery discount calculated in those studies or not?
Recovery, how they calculate
discount? Yes. If they said that only 50% or 80% of the primary dose is used, you say you multiply it by 0.8 or so. Do you know that, Marina? If or I think they just summed it up. It's just total dose. There is no time factor.
Right. So if that's the case, then it's difficult really to know, right? Because it depends on what's the time interval between the primary course and re-irradiation, right? Will affect the outcomes.
Yeah,
and
I understand.
It might be different for all different endpoints. You might have a different time factor for the bladder different time factor for the rectum, because these are different kind of tissues, different. So it's the most complex situation we can imagine. These re-irradiation settings, of course.
University of Michigan has the recommendation, but they also generalize it quite a bit. So for all organs, it's all the same discount factor. So that they simplified the problem, but they do apply the discount. So it does matter what's that time interval is. So I was wondering if maybe these studies can do some type of post hoc analysis, applying that factor and seeing how it affects their outcomes. Mm-hmm.
I have a question about the evaluation. What those could be appropriate from the brachytherapy at the surface or at the depth 5 millimeters? What reasonable to summarize from those courses?
Yeah, we are always trying a T2cc. In your situation, that's not possible because you don't have the information of a T2cc. But you could assume that the T2cc is more the 0.5 and not so much the maximum at the surface.
Yeah,
or you mean this is the cumulative bracket dose for the target?
Yeah. If you evaluated those for the target, what's more appropriate, surface or depth 5 millimeters?
Actually, it's the target depth. So if you say
5.
your infiltration is 5 millimeters approximately, then it would be more the 0.5 centimeters. If you say it's only 3 millimeters, it would be 3. So I would link the target to the actual infiltration depths, if you can somehow estimate this. It's difficult, of course.
But in these terms, the surface dose would be scared, actually. Or not? Because it's higher. Surface dose would be...
Yeah, it's much higher, but it's a little bit like in cervix, we also look on a D90 or a D98. So we are looking more on not on the minimum dose, but more on the dose which is on the periphery and not so much on the maximum. So we are not looking on the D10 in brachytherapy, for instance, or so. So probably it's more a depth dose. But again, we don't know. And I think what we have to do is we have to record those data. I think you have to record both. And then after some time, when you have more experience and more patients, you have to look and analyze this retrospectively. No one has really done this. This is a complete chaos in the literature because they have all used a little bit different ways to sum up and record and report doses, unfortunately. There is no common language. Everyone is publishing using their own methods.
Yes. So in fact, in this case, it was the progression was on the side of the vagina, but sometimes, and we also had the patient it was on a scar, so the upper part of the cylinder was involved if you use cylinder, but in the literature was mentioning of using Fletcher applicator without the central part in order to have a better normalization into the depths of involved tissues, or as you mentioned, probably using needles, but that when you have access to interstitial brachytherapy. If we don't have access to interstitial, I think that it was published also, and it provides a better coverage for the target if you use just ovoids without the central part of the Fletcher applicator.
I agree. We are using now this Geneva applicator without a tandem for such cases. So it's like ovoids without any tandem when you have only the upper part involved, and you can little bit fine tune more to the left, more to the right, more posterior. So this gives the opportunity when you have this in the upper part of the vagina with a cylinder, you can only do it rotating, but exactly as you just said. This is. I mean, you explained it already. Right. Excellent. Yeah.
Also, we have a question in the chat from Natalia. At 8 p.m., since in this type of questions, when radiation is, so Elikumedel is the only person in the town. So at 8 p.m. meeting 2026, there was a study showing evidence that cervical cancer alpha beta was closer to 3 rather than 10. So if this is confirmed, if you have heard about this, what then there is application for brachytherapy if in fact alpha beta for cervical cancer is closer to 3 rather than 10?
Is this meant for the re-irradiation setting, or
in general?
In general.
In general, there is this is a strange abstract.
So you don't believe that it's closer to?
No, I don't believe that.
Okay.
I don't believe that we have now evidence from MRES-1 and MRES-2. It's altogether 3,000 cases, and the dose response curves work very well with an alpha beta of around 10 grade.
10.
And yeah, but this is really the truth. There is some arguments, and they say if you perform a re-irradiation, then your cells they already have a history of radiation, and the alpha beta might change in the re-irradiation setting. So therefore, I ask what was meant with this abstract. So there are some hypotheses, speculations, but I think good ideas behind that the alpha beta could be different in the re-irradiation setting. This is something else, you know what? Therefore, I ask if it's general or not. So what is written here at AAPM meeting? I don't know who was the author. If this was, for instance, our colleague Dorin Dodor,
No,
has this. No, it was not him. It was another one. Okay. Because he had this idea of changing the alpha beta in re-irradiation settings.
I see. But I think that the implications can be, if that's really confirmed, then for hypofractionation for external beam, for example, because with brachytherapy, you're already hypofractionating, right? But for brachytherapy, if alpha beta is closer to 3, like prostate cancer, then maybe there is more evidence for doing hypofractionation for external beam.
It's still not lower than normal tissues, so it's kind of equal. But you mentioned also for radiation settings that alpha beta might change. Would that have any type of implication? Because when people re-irradiate, they tend to hypofractionate. But from many experiences, it seems like it's usually better for patients to have a small doses. So what is your opinion for that? When you
this is just a hypothesis. This is a hypothesis, but I find it interesting, and I think it might be worthwhile to. What are the implications if the alpha beta rate is lower? This has certainly an impact on the fractionation schedule. This is as long as we keep it the same, it doesn't matter. You know, it's all the same. But if we change, I think this was already. Natalia, I think you mentioned this already. I think hypofractionation could then play a role in this setting as well. Yeah.
Yeah. We do have a question from Dr. Tatiana Sulis. So the question is for Dr. Sokolovska. Did you have complications immediately after finishing the radiation course? If yes, what kind of complications?
Thank you for this question, Dr. Sulis. Actually, we had an edema. Patient had an edema of genitalia after ABRT course. Even more during the last week of ABRT course. But in a week, these complications was resolved, and she passed the brachytherapy without any complication, any side effects. And after finishing, there wasn't side effects, acute toxicity at all.
Thank
and
you.
currently she hadn't late toxicity in the re-irradiated area.
Thank you. I do have also general question about cylinder applicator for Christian. Since I think many of our colleagues start to using imaging more and more for brachytherapy, we read from the literature that normalization point for cylinder is 0.5 centimeter, as Marina here mentioned. But we also, when speaking in a practice with the physician, we know that most of recurrence can occur in a stamp, in a scar of surgery. So there is a tendency to deliver a little bit more dose to that part to normalize in an axial of cylinder application a little bit more. What is your practice in your settings? Do you uniformly normalize to 0.5 centimeters the prescribed dose, or you choose the hotter point to be at the top of the applicator?
Again, if we talk about post-operative endometrium, it's a complete different story. I think you don't need imaging. You can do it with a fixed length and 0.5 centimeters in depth. Here we are treating actually a target, and as soon as you have a clinical examination and as soon as you have a CT, you can delineate this target. And when you delineate the target, we are not using any surface or dose points anymore, but we try to do the same as in cervical cancer primary cases, that we try to have 90% of this target should receive a dose of, let's say, 50, 60, 70 gray for the radiation type. So we really try to use the image guided approach for that, and we left the fixed prescription to a surface or to a point dose, which is difficult if you have no CT. Then you have to somehow, but you can still say, I want only on the left side in 5 millimeter distance, and then you can only load this type of ovoid. You know what I mean? You can try to do that, but of course, the standard would be to delineate something, some kind of target.
Thank you. If you have some questions more, please type it in the chat. You can type it in Ukrainian or English, or turn on your microphone and ask your questions in any language which is comfortable for you. If there are no questions at the moment, I think we have 1 or 2 questions left from people previously asked, and we wrote that question down. I think would be better question if on the first stage of this treatment was in fact used cylinder tandem ovoid treatment. So that is a general question about brachytherapy we had. We have a lot of lengths and angles of tandems and cylinders needles on the market, but what size do we need more often, and which one we should order when we get a new brachytherapy equipment in our center? So that is a general question from previous lectures.
If that is to me, yeah, I have to say I would not. So, for instance, if we order applicators, we are not ordering sets anymore. You know, you have a set, and you have all kind of angles and variations, and then you only use 30% of these applicators because the others are very exotic. Of course, this depends very much. I mean, what we have is, this depends on what kind of applicator. Of course, we try to have small, medium, and large ovoids, or small, medium, large ring size, because you have always these variations. I think the tandem length is also variable. We have a 4 centimeter, 6 centimeter. I have never seen that we have 7 or 8. You know what I mean? So it is more a little bit limited to 4 or 6. And what we are really using almost always is a fixed angle And now it has to be very careful because the terminology is different in Varian and Electa, how they measure the tandem angle. Do you know what I mean? That the angle between what the tandem does. And we are using, and we call it 30 degrees. So
that
it's
is
the
for
more,
Electa.
yes. And we are not using the 45 very often, almost never. But please don't just use what I say now, because your type of application could be different, your experience could be different. So I would be careful to give a general recommendation. And I think all of you have enough experience from your current equipment. What is your equipment? What are you using? I also guess that you have, in most cases, it's the same angle.
Yes, we do use 30 degree tandem.
Yeah.
And also with Electa, but some people are switching from old equipment. I'm not sure what is the angle is there, or they have the set range. But I think that is a quite middle choice. Yes.
Yeah. But don't buy the entire set, because the entire set, sometimes you have 30 degrees, but also 45, 60. And this would be a completely undeflected uterus, or 0 degrees, which would be a completely, so you will not use it. So I think 30 degrees, maybe 45. This is what will satisfy you in 99% of cases.
So another question, I think, for equipment part, then when we also buy this equipment, do you use actually steel or titanium needles for cervical brachytherapy? And how many needles per patient per treatment do you typically use?
We are not using steel needles because we are using an MRI. That's just not possible. Also with CT, steel needles cause a lot of artifacts. And when you have the steel needle in, you don't see the target fine anymore, because the steel needle is not good. Actually, there were titanium needles available in the past, but they disappeared from the market. I'm not completely sure from where they came, if they came from one of your neighbor countries, or for sure they came somewhere from that region. And I don't know if it's because of the war or because of whatever implications. Titanium needles are not manufactured anymore. I'm not completely sure if it was Kazakhstan or if it was Belarus. I don't know, but they came from this region. So we have no titanium needles anymore. So we are only using plastic needles. And
Those are not reusable. Or they are?
not reusable plastic needles. I know that Varian has reusable plastic needles. Electa not.
Okay.
And normally you don't use that many needles. If you have the tumor just on one side infiltrated, it's 1 to 2 needles on one side. If it's on both sides, it's 1 to 2 on each side. So altogether, maybe up to 4 needles. Only in very large tumors, where you also have oblique, freehand, then sometimes you can have 5, 6, 7, 8. But this is rare. The typical case is 2 to 4 needles per patient. They are not reusable. I know they are expensive. Varian is reusable, and Electa, they say it's not. I think somebody answered here, we use reusable plastic by Varian. I know many are using that. Electa, this is your choice. If you are able to reuse them in the same patient, maybe that's your decision in the end. But Electa, of course, recommends to not reuse them.
Thank you very much. If someone has more questions, please reach out and you can ask your question now. If not, Lesia, please.
Hello, Christian. Hello, everyone. I have a question regarding the post-operative brachytherapy after EBRT. what indications are for brachytherapy boost in the post-operative settings after EBRT?
It's a typical post-operative endometrium case.
No, cervical.
Cervical. Yeah, we would need Primoz here, or maybe one of you can answer this. We don't see post-operative cervix cases. Of course, when they have a recurrence after surgery, but usually we are using brachytherapy only for primary brachytherapy cervical cancer cases. Of course, for endometrium it's different, but this is also declining. You know, in the past, when I came to the department, every week we had 5, 6, 7, 8 cylinders for post-op endometrium. But this is, of course, this is completely almost gone. This type of endometrium cases.
Thank you very much. And yes, regarding endometrial cases, do you use EBRT plus brachytherapy?
Yes, but less and less, because I don't know what happened to these patients. This patient group is getting smaller and smaller, which is good, of course, for the patients. Yeah, it's both. Yeah, it's a typical, and there we don't do any kind of image guidance, because this is just a dose of 5 gray to 5 millimeter around the cylinder. It's a very easy, simple, straightforward treatment.
Yes, thank you. And I will ask maybe Primoz about indications, for combination of
Yes.
EBRT and brachy. Yeah, thank you very much.
So in this case, there is no chance of overlapping the dose from the brachytherapy and external beam, right? Of 5 times 5, you said, right? To the 5 millimeter dose and external beam dose, which is delivered to lymph nodes primarily, or also to the area.
Yes. Yep.
Okay. Zoya, you can ask your question.
Yeah, thank you very much, Marina, for a very interesting presentation and for your for showing your experience. It's very difficult case. Maybe a little bit answer for lesser questions because I also have some experience in brachytherapy. Sometimes we have cases when we have L1 resection. If this is not a cervical cancer T1 and we have some extension in the vagina, and after operative treatment have one L1 resection, we I think must use brachytherapy in these cases. And I think other options, it's decide on multidisciplinary consilium if we have some high risk of recurrence in the vagina, or also I have experience when we have T3s and patients have mets in vagina. We also after operative treatment continue treatment with brachytherapy in tumor on vagina.
Thank you. So if there are some more questions, comments, or if there are no questions at this point, we will be very happy to see all of you on the concluding session, which will be Q&A with Primoz and Christian. And please continue with your online training and be in time to finish it before September 15. Thank you very much, Marina, for excellent presentation. Thank you very much, Christian, for being here to answer our questions. And thank you all for participation. Слава Україні! До побачення!
Героям слава! Thank you, Christian, again. Thank you, Marina. Thank you, Sergey. Bye,
Thank you to all.
Дякуємо, до побачення.